Sir, we are live now. You may start now, sir.
Thank you very much. And at the outside, I would like to thank Ocular Trauma Society of India, Dr. Devin, and my teammates, Dr. Mehul Shah, Dr. Jayanta, Dr. Shakeen Singh, Dr. Nirmal, Dr. Pariyar sir, and all from the Ocular Trauma Society of India. We all know last week was the glaucoma week, which is celebrated for a week because of the incidence of glaucoma and glaucoma being a silent killer. So we thought that we should discuss and about the traumatic glaucoma. So today's theme or topic is to discuss the traumatic glaucoma from mechanism to management. And glaucoma per se is traumatic glaucoma is definitely the condition which can appear immediately, maybe after a few days or maybe after a few months, so or even years. So that is something which the patient has to be informed, and the gravity of the problem and the issues which are associated with it, so everything has to be discussed. I am very happy and delighted to welcome you all from Ocular Trauma Society of India, and Dr. Vinita and Mayuri madam, and all the speakers who are here, Dr. Prasanna and Dr. Alok, that they have given their consent to present, and Dr. Murli, Dr. Sanjay Mishra. So they all are the speakers, and panel discussion will be done by the others, and all the learned speakers are here, learned panelists are here, and Devin Tully will moderate this. And I look forward for a wonderful session today. Thank you.
Thank you, sir. In the interest of time, I'll request Dr. Mehul to please invite the first speaker, and time will be about 10 minutes. Mehul, sir, are you there?
Yeah, I'm there.
Yeah, please invite the first speaker, sir.
Dr. Vinita is the first speaker.
Yes, ma'am. Dr. Vinita, everybody knows her and she does not require any introduction. She will deliver the first talk today. Please share your
She
slides.
is from Bhopal, and she was the secretary and organizing president of the GSI at Bhopal in the year 2025. So welcome, Dr. Vinita.
Thank you, Dr. Bhasin, Dr. Mehul, and Trauma Society of India. Hope my slides are visible. Hello?
Yes,
Yeah,
yes.
visible. Yes,
My
yes,
slides
visible.
are visible? Okay.
Yeah,
Yes,
visible.
yes.
So the first topic is etiopathogenesis of traumatic glaucoma, which is very important because it is multifaceted. I'm not able to move. Oh, yes. So the traumatic glaucoma is a type of a secondary glaucoma which can occur after any kind of a trauma, be it penetrating, blunt, chemical, radiation, or thermal injuries. And the incidence with the penetrating trauma is 2.67%. Initially, they may present with the low intraocular pressure, but later on there could be an increase. The blunt trauma has a more incidence of glaucoma amounting to 3.39%. There is usually two peak incidences of glaucoma after a trauma, which is less than a year and after 10 years. So after 10 years, the incidence might go up to 10%. And by the time the patient may forgot the trauma. So as far as the pathology is concerned, so basically it's multiple, and it is the combination of the healing response and the initial things which happens following a trauma. There could be a steroid response because of the inflammation control steroid we use, and later on it could be as bad as fibrosis, cirrhosis. So we will see one by one. So basically, it is the timeline of the injury which is more important, because in the early 1 month, there will be different causes. Between 2 to 6 months, which is intermediate onset, the causes could be something else, or the mechanism of development of the glaucoma can be something else. And in the late onset, after 6 months, the causes could be different and etiology can be different. So normally in blunt trauma, what happens is there is an anteroposterior compression with the equatorial expansion. Because of that, there is a transient rise in intraocular pressure, which damages the anterior and posterior aspect both. So whenever there is a mechanical tear or whenever there is an injury to the trabecular meshwork, we can see it sometime during gonioscopy, and sometimes it resolves eventually without any treatment. So it can give rise to an early onset glaucoma because of the direct tearing of the trabecular meshwork. So there will be a release of pigments, and these pigments are going to obstruct. So it will be more like a pigmentary glaucoma. Sometimes this tearing in the late stage, they form a scar. And because of that, there is a disruption and the fibrosis, which leads to the raised intraocular pressure in the later stages because of the difficulty in the drainage. So the direct impact of the injury can disrupt the area where the main drainage occurs, and this drainage can be obstructed physically or by the pigment and can lead to the early and late onset glaucoma. So we can see sometime that instead there could be a ciliary body cleft. So when the cleft like this forms, normally the pressure goes down. So we need to remember that each and every etiopathogenesis will lead to a different permittable combinations. The inflammation is the one of the earliest sign of the trauma, and because of the inflammation, the blood aqueous barriers disrupts the protein and blood cells. They clog the trabecular meshwork, and this clogging leads to the obstruction and the early rise in intraocular pressure. Why always I am saying a rise in intraocular pressure? Because it may not lead to glaucoma. So the raised intraocular pressure is not equal to glaucoma until unless there is an optic nerve and disc damage and the field damage. We may just say that it is a rise in the intraocular pressure, which is temporary and may, with the medication or without medication, it will control and may not lead to the glaucoma eventually in the early stages. Sometimes there is a trabeculitis. So there is a direct inflammation to the trabecular meshwork. So there will be an outflow of facility which is be reducing, and that can lead to the increased intraocular pressure. So you can see the gonioscopic findings, which will be dealt with the subsequent speakers. The hemorrhage is the commonest cause of the trauma, and that trauma can lead to a secondary glaucoma. The commonest cause of the glaucoma are the raised pressure is hemorrhage following a trauma. There could be a direct tearing of the blood vessels because of the equatorial expansion, and these equatorial expansion can lead to a blood from the iris and ciliary body. And the fragile vessels, especially if the patient is hypertensive on anticoagulants, are having sickle cell trait, they will rupture and they will lead to an amount of the bleeding. So the sickle cell trait or the sickle cell patients needs to be checked into. So they can lead to an damage and the bleeding in the different parts of the eye, and the hyphema being the commonest. So 1/3 of the patients can have hyphema, and there could be fibrin in blood and the platelets in the trabecular meshwork, which will be. So the
Dr.
hyphema
Mehul,
can be.
please mute yourself.
So the hyphema can be 1/3, 1/4, or 50% or 100%, depending upon the amount of the damage and the time and the bleed, and that will definitely guide us the treatment and the prognosis of the case. If it is in the choroid, definitely there could be an raised intraocular pressure because of the forward movement of the iris lens diaphragm leading to angle closure. So sometimes we need to drain these choroidals. So if you know the pathology, probably the treatment becomes easier. Same way, there could be an injury to the lens, and because of the acute injury to the lens becomes swollen and subluxated, whether anterior or posterior, will lead to a pupillary block and angle closure. Sometime in the posterior one, it is the vitreous which clogs. So if there is an immediate injury, there will be an injury to the lens. There could be an hyphema, there could be an inflammation, or there could be a damage to the trabecular meshwork. So it is within the month. But if it is little more late, maybe 2 to 6 months. So basically, it is the synechia's post-inflammation which is responsible for the glaucoma, or in the penetrating injuries, it is the epithelial downgrowth. The ghost cell glaucoma is also one of the commonest cause. If the blood remains there, it is lead to a khaki cell formation, and these khaki cells, they are very rigid, and they are called as the Hannes bodies. So it is nothing but a degenerated hemoglobin because of the long-standing hyphema, which is there into the trabecular meshwork or aqueous outflow, and it leads to the damage to the trabecular meshwork and outflow facility. It happens only in cases of vitreous hemorrhage. It doesn't happen in hyphema, excuse me. Because in anterior chamber, there is a continuous circulation of the oxygen. And because of this oxygen, there is a rapid circulation, and there will not be any khaki cell formation. Late onset is like after 6 months. So it could be phacolytic or phacoantigenic, where there is a release of inflammatory material gradually from the lens, and it will lead to a lens particle which is engulfed by the macrophages, and they obstruct. Angle recession is one of the commonest cause of a trauma, and it is also a late onset, where there is a tearing between the circular and the longitudinal fibers of ciliary muscles. There will be a scarring over the time, which gradually covers the trabecular meshwork and impairs the aqueous outflow facility. So when there is an angle recession of more than 180 degrees, there is a risk of development of the glaucoma, which could be as high as 4 to 5%. And if it is 360 degree, it could be even more, up to the extent of 24%. So we have to be very careful in diagnosing our cases and treating. The treatment depends upon the etiopathogenesis. One form of the glaucoma, which is even rare, is a hemolytic glaucoma, where there is a release of the sidrin material, and it can lead to the hemosidrotic glaucoma also, but they are very rare form of the glaucomas. When there is a little late dislocation or subluxation because of the trauma, there could be an open angle, and then also you can see the traumatic glaucoma, which is basically due to the intermittent closure. So if you see the conioscopy, you may have the open angles, but in spite of the open angles, you can have that glaucoma, which is lens induced, and it could be an occult phacolytic glaucoma. There will be an obstruction, which is by the vitreous, or may not be a physically anteriorly displaced. So there are certain smaller things which clogs the pathway, and may not be the actual shallowing of the anterior chamber, or the dislocation or subluxation of the lens. The lens particles may come forward, release the inflammation, increase the inflammation, and they will also lead to the blockade of trabecular meshwork. So ultimately, the pathway which is there, which is being blocked by the trauma, and it leads to the problem. It could be the inflammatory cells, it could be khaki cells, it could be proteins, it could be lens particle which clogs it. But if it is a penetrating trauma, probably beside all these mechanisms, the trauma per se can reduce the intraocular pressure initially, but later on there are certain mechanisms which can further set in penetrating trauma, and can lead to more faster damage and formation of the synechies, the lens injuries, and the lens hydration, which leads to the glaucoma. So the penetrating glaucoma per se also can give rise to a damage in the later stage, and we should be looking into these damages, the lens particle, the inflammatory, the pupillary block, and even sometimes the keratoconus fistula following a trauma can lead to a raised episcleral pressure and affects the drainage. So there are the various causes, early onset and late onset can be trabeculitis, uveitis, disruption, hyphema, lens-induced and choroidal hemorrhage. The delayed onset could be angle recession, synecdoche, ghost cell glaucoma, phacolytic. The delayed closure of cyclodialysis cleft could be another cause. And lastly, the rhegmatogenous retinal detachment. Initially, it can lead to a lower pressure, but then there is one phenomena in which even the vitreous hemorrhage, the RD can also lead to the raised intraocular pressure. So to conclude, the trauma is a common cause of ocular morbidity. It can occur at any age, and there are multiple factors which are involving in the development of the glaucoma in combination. Identifying these causes are very important, which will help in treating the patient. Sometimes these injuries may go unnoticed, and we should monitor the patient of patient of trauma continuously, not only for months but also for years together, as we have seen that it can occur 10 years later also. Thank you so much for the patience listening and giving me this opportunity.
We can have very brief comments from Parihar sir and Dr. Mayuri on this topic, and then we'll have Dr. Murli's talk. Parihar sir? Dr. Mayuri, you want to say something?
Was very nicely presented. All the mechanisms at a different level is been presented here. What I would like to add to this, the counseling of the patient. You have treated the patient at that particular patient, but the lifetime follow-up is must. The glaucoma can manifest anytime in the lifetime. Particularly in the children, they have a blunt trauma while playing the cricket or badminton, shuttlecock injury. So those are the patients should be informed that you need lifetime follow-up. Glaucoma can occur at any time. And treatment is always dependent on the mechanism of that cause.
Parihar sir,
Thanks.
anything to add?
Dr. Vinita and Mayuri has nicely elaborated, and it was very comprehensive. I must compliment her. Basically, traumatic glaucoma, as it is, the first is the trabeculitis. The most important, and second is the ghost cell, as it has been highlighted. We have been treating such type of cases in different combat operations, and I remember that initially the pressure goes very high, and despite maximum medications, systemic and topical, they were not responding. But ultimately, if you are able to manage the pressure for a period of 3 months or gradually it starts declining, and most of them, if they don't need any glaucoma surgery in the future. But yes, the long-term prognosis in such cases is always vulnerable, because particularly if the patient who has been engaged is on the elderly or hypertensive or diabetic, they have higher chances of clogging of the trabecular meshwork. So overall, it's a very complex, multiple etiology and mechanism of actions are concerned. So best thing is to keep on observing and managing as and when the situation arises.
Thank you, sir. We can, is Shakeen sir there? Shakeen sir, are you there? If you're there, you can please invite Dr. Murli. Otherwise, I'll request Dr. Mehul again to please do the honors. Dr. Mehul sir, can you invite Dr. Murli Ariga?
Please unmute yourself, Dr. Mehul.
All right.
Murli,
Yes.
I invite Dr. Murli to give his talk. Dr. Murli is from Chennai and from Shankar Nadralaya, a good friend of mine, and doing wonderful work in glaucoma. I think
Sir, everyone's friend. He's everyone's
Dr.
friend.
Murli, please share your
Yeah.
screen.
Yeah, and for this, I request, after this talk, I'll request Dr. Madhu and Prafulla sir to please give brief comments. Sure.
Thank you, Dr. Mehul, and thank you, Ocular Trauma Society of India, Dr. Basin, and of course my close friend Devan Tuli, my teacher Dr. Kamar, and all others. And nice to be here this evening. And even though it's a short notice, I think it's an excellent program to put together the webinar on traumatic glaucoma. And my talk is going to be very brief and mostly focusing on the topic which has been allotted to me, speaking on the what to expect and what to see in the anterior segment, especially the anterior segment, and then the findings on gonioscopy. So as Dr. Vinita has highlighted in great detail the types of trauma which can cause the raised intraocular pressure and glaucoma, and also the pathophysiology. I'm not going to go much into the pathophysiology or the types and classifications of the traumatic glaucoma. But I think just to get a perspective as to what to expect in different types of injury leading to the raised intraocular pressure, broadly we can classify the raised intraocular pressure and so-called glaucoma after trauma into either we have the injury which is a blunt trauma in the past or recent and a penetrating trauma. So this we have to differentiate. The findings will obviously be different depending on the etiology of what caused the injury. Similarly, the glaucoma occurring after blunt trauma is further sort of subclassified into early onset and late onset raised intraocular pressure. So keeping this in mind, our findings and our what we need to document would be different. So blunt or penetrating, and in under blunt trauma, which is probably more of leading to changes in the angle and so on and bleeding, that would be early onset and late onset raised intraocular pressure. Of course, then you have the other types of post-traumatic glaucoma, including chemical, sports injury, occupational, thermal, electric, radiation injuries are a little less common. So the younger age groups are obviously more into the sports trauma, assault, and road traffic accidents and those kind of things. The elderly are more related to the falls and other kinds of injuries to which they are more susceptible to. Let's look at basically the traumatic glaucoma, what Dr. Vinita referred to. I think the transient anatomic deformity that causes this force, and like she clearly mentioned, the expansion at the equator is the main reason why we get the damage to the trabecular meshwork, the angle damage, and also leading to the inflammation, which she clearly mentioned, and also about the bleed into the front of the eye as well as the back of the eye. And the bleed in the front of the eye, obviously, we call it hypema. So the late onset glaucoma, which can happen much later in the disease after the trauma, is a tear which occurs between the longitudinal and circular layers of the trabecular, the ciliary muscles, and widens the ciliary body band, which is seen on gonioscopy. And any angle recession of say 180 or more generally increase the risk of glaucoma. Sometimes they say people are more predisposed to raised intraocular pressure after trauma, something like a pre-existing early mild glaucoma. They say the other eye also sometimes shows signs and symptoms of glaucoma in a patient who's had angle recession. So they are more predisposed and more susceptible to angle recession related glaucoma. Some patients are. Similarly, I think she also mentioned about the ghost cell glaucoma. We need to clearly look at gonioscopy and identify these khaki cells. And as she mentioned, that these are more common with the hemorrhage that occurs in the posterior segment, not the hypema which happens in the front of the eye. The rarer types of raised intraocular pressure like hemolytic and hemosiderotic is due to hemolysis, and we're not going to discuss that now. The penetrating injury traumatic glaucomas actually depend on the nature of the penetrating injury. The mechanisms are usually complex, multiple, and interrelated, not just one factor like inflammation or blood clot, or is this angle recession, or is it inflammation or synovial closure. Multiple mechanisms, including the lens, which could be the culprit, the shallowing of the chamber, the disruption of the lens capsule. So each of these etiologies can lead to raised intraocular pressure. Therefore, the findings have to correlate with what you see in the front of the eye. And then, of course, you have the late onset epithelial downgrowth. And sometimes you have the penetrating injuries, and you have the foreign bodies, which can cause siderotic glaucoma, and even sometimes the gonioscopy will show you a foreign body in the angle. So needless to say that we need to do a comprehensive eye exam. We need to document everything. There's significant medico-legal aspects and of documenting trauma due to any cause. It could be occupational, it could be accidental, it could be any kind of injury which the patient might have been subjected to, even sports injuries. Documentation is the key. Visual acuity, visual inspection of the globe and the adnexus of a signs of retained foreign body anywhere in the fornix, in the corneal foreign bodies, in the eyelid, in the orbit. And similarly, looking at the conjunctiva for apparently innocuous looking lacerations, which may actually hide a deeper penetrating laceration. The corneal lacerations, corneal telltale injuries of penetrating injury, and of course, leading to injuries to the lens and hyphema and so on. The presence of hyphema and the presence of Kaki cells has been mentioned, and carefully we need to look for eyelashes, glass particles, foreign bodies, lens particles in the case of damage and findings in the anterior chamber. In the iris, we need to see for the sphincter tears, which are very easily missed. A dilated kind of a traumatic mydriasis, quite common. And also you might find iridodialysis, which is somewhat obvious with a D-shaped classic iridodialysis. The lens can show subluxation with a phacodonosis, iridodonosis, localized lens opacities, the rosette type of cataracts, the pigment dispersion both on the lens surface as well as in the angle. And of course, the anterior vitreous can show the pigment and blood clots and abscesses and so on. So some of the pictures which of our patient which I would like to share, put together, which we had hurriedly put together. You see this patient with a apparent innocuous looking subconjunctival hemorrhage came in with a hit onto the eye. And then we found that the vision was very poor, and then we also found that there's a small tear in the sclera, which we only found because of the unexpected very low intraocular pressure and the tear, which is actually the little posterior to what we can see in the front of the eye. You can see the eyelid injury as well. Then, of course, you have this fish hook type of injuries and injuries which are coming in looking apparently quiet, but when at presentation. And these are sometimes obvious, but again, you need to document what was actually happening. Then, of course, you have the traumatic mydriasis and the small sphincter tears of the blunt trauma, the coup and contra coup injuries, which result in this change in the damage to the iris sphincter. The iridodialysis and the lens change, the lens damage is quite obvious in these kind of patients. Many of these injuries actually we were noticing in the last few months following the Diwali season of firecracker injuries. We had about 6 to 10 patients having severe injury to the front of the eye, some of them having this minor injuries like traumatic mydriasis and sphincter tears, some of them having the dialysis, traumatic cataract, mild subluxation of the lens, and a few of them had even total dislocation of the lens into the vitreous cavity. And some of them, they had to lost one eye, and the other eye was managed partially, managed to save the vision partially. The firecracker injury is something we really have to keep in mind. And of course, the hyphemas can be of varying degrees. You have the smaller degrees of hyphema. You have the huge, the 8-ball type of hyphemas. They have to be dealt with according to the intraocular pressure, the duration of the bleed, and of course, the medical history of the patient in whom kind of bleed which has occurred. A penetrating injury with an iris prolapse, lens damage, a shallow chamber, all of this is quite obvious, but has to be dealt with very carefully. And sometimes you have this injury, like in this patient, we had the entire lens coming to the front of the eye, total anterior dislocation. And these are all findings which you need to document and carefully monitor and deal with it in a surgical sense. A word about the gonioscopy. A very careful gonioscopy should be performed only after a penetrating injury is ruled out. Do not be in a hurry to do a gonioscopy moment the patient has come with an injury to the front of the eye. Examine the patient on slit lamp, document everything, document the vision, and think about the initial medical management of the patient. Do not be in a hurry to do gonioscopy. I would recommend that you do a gonioscopy maybe a week or two or even a month later to examine the angle for the trauma-related injury to the angle, that is the looking for angle recession, looking for changes in the angle and so on, to rule out what foreign bodies are lodged in the angle which are not visible on slit lamp examination. The iris root displacement posteriorly in a widened ciliary body band is a classic sign of angle recession. Sometimes you see a grayish-white membrane covering the angle, but this is uncommon. Disinsertion of the ciliary body from the sclera will lead to what we call as a cyclodialysis cleft, and often is associated with a hypotony rather than increase in the intraocular pressure. And very often you will find trabecular meshwork flaps hinged at the level of the scleral spur signs of tears, the trabecular meshwork, and of course, stone iris processes with blood in the angle and Schlemm's canal. All of these things are quite obvious on gonioscopy, but mind you, I'm repeating that do not do gonioscopy in the acute setting. Make sure you learn to recognize the angle structures and clearly see this is a very classic kind of an angle recession. You see the pigmentation anterior to the trabecular Schwalbe's line. The trabecular meshwork is here. You see the wide ciliary body band with the angle recession. You see the scleral spur. You have trabecular meshwork, the scleral spur, and you see the widened ciliary body band clearly showing you the recessed angle. And this angle recession, we need to document the extent of the angle recession and the related findings due to the trabecular meshwork pigmentation. Make sure you also compare with the other eye. Other eye is the extreme reference point for looking at the gonioscopy. But the other eye will give you a clue as to what is actually happening in the affected eye. And this is a cyclodialysis cleft, as you can see here. Entire ciliary body has been disinserted, even though in this patient, intraocular pressure was not very low, but this is a classic cyclodialysis cleft. Often you will find that apparently innocuous looking injuries, a small scar in the cornea, and then you will find the raised intraocular pressure, pigment dispersion. You find this kind of a foreign body also in the angle. So my take-home message from the talk here today, a brief talk here today, is about the role for a very careful gonioscopy a few weeks after the injury. Do not be in a hurry. Compare with the fellow eye, especially the gonioscopy, to make sure that you know what has actually happened. The damage-related changes are noted in the eye which is injured. Document all the findings, including the extent of angle recession, of course, the intraocular pressure. Keep monitoring the vision, the intraocular pressure at regular intervals. As she has also mentioned, and Dr. Kamar also had mentioned about the need for regular follow-up. This is long-term, even though the chances of raised intraocular pressure and glaucoma developing following trauma is not so common. It's something like, say, 2 to 5% or maybe 10%, depending on the extent of angle recession. Sometimes the extent and the nature of the angle recession does not really correlate with the intraocular pressure and predictability of how any patient may develop in the glaucoma in the future. Therefore, the need for regular follow-up and regular monitoring of vision intraocular pressure, especially in young adults who have undergone this injury, is extremely important. I thank you all for the patient listening.
Dr. Madhu and Dr. Prafulla for brief comments, please.
Can I speak?
Yeah.
Yeah. Dr. Murali has actually left hardly anything behind to discuss. He has extensively covered everything. But still, one thing I'd like to comment that in post-traumatic glaucoma, especially in presence of subluxation of the lens, I'd like to add that we should be very careful while dilating the pupil. When we want to do a comprehensive examination in presence of little bit of subtle subluxation, which can be evident by little bit of irregular depth of the anterior chamber. And sometimes we may have some clue that the center of the slightly sclerosed nucleus, center of the lens, it may be slightly sagging down. That can give us some clue that the patient may have subluxation. And gonioscopy may not reveal anything, but we should be very careful in dilating these patients, because very recently I found the patient went down after dilatation. Everything was okay. The patient talked to me, patient called me in the evening. The patient was having intractable pain. In fact, the dilatation can sometimes actually hasten the development of angle closure glaucoma, acute angle closure glaucoma. The next, in the evening itself, I called the patient. I found that the lens has come to the anterior chamber. Although while during examination, there was a little bit of subluxation. So we should be very careful in those type of cases. Otherwise, in late cases of uniocular glaucoma, we have to be very careful to do the detailed examination. A comprehensive examination in gonioscopy can give some clue. Apparently, there may not be direct evidence of previous trauma, but a careful gonioscopy in the form of, say, as Dr. Murali has said, a small pigment clump or little bit of angle decision, it can give us clue that the patient might have injury in the earlier period. And another thing, very little cyclodialysis clip, very small cyclodialysis clip, sometimes we may miss during gonioscopy. We have to be very careful. In fact, those patients who are having unexplained low intraocular pressure on gonioscopy, If we cannot find a cyclodialysis cleft on, especially in the late cases, we should not leave immediately. We should repeatedly see different areas of the angle very carefully, and suddenly sometimes the cleft may appear and it may disappear again. With little bit of compression, it may again reappear. So that is another point I'd like to actually say. We'll be very careful.
Thank you, sir. And we'll come back to you for more comments. Go ahead, ma'am.
Okay, so Murali has brought out things very beautifully. There's no doubt about it. But in this, there are two fundamental things. First is the angle changes. First 2 weeks, you really don't get to see the angle because that is the time for bleed and rebleed. So first 2 weeks, we manage the IOP based on the clues, and the clues have been truly described by him pretty well, that you see hyphema, that you see traumatic mydriasis. So these are all telltales. So you may be seeing hydrodialysis. These are all telltales that something is really wrong with the angle. So in about 8 to 10 days, the time for secondary bleeding is over. And that is the time I'm talking right now of the closed globe injury and not the open globe. So then after 2 weeks, we do a gonioscopy. Gonioscopic findings have been beautifully described again by Murli. Just one or two more things is that a very normal looking angle, say a few months after trauma with high IOP and not having any angle recession does not mean it's not a traumatic glaucoma. Many times you have injury to iris, injury behind, and the angle actually gets a bit fibrosed and we have no way to really check. And coming to cyclodialysis cleft, actually these clefts are pretty much there, and this is the place that we should not be really relying totally on the gonioscopy. The moment we see a closed globe injury, shallow AC with hypotony, there is no doubt about it clinically, but we must confirm on the imaging. And for that, if nobody has if we don't have an UBM, ASOCT, and not putting on the angle, go a little more behind the angle. And usually if you go 360-degree, the cleft is visible. So that is, it's worth hunting for that cleft because that may require treatment if it's big, or if it's not big, it will not require treatment. So if there is angle recession, then that we all know, like maybe a little bit about hyphema, which is very important actually in traumatic glaucoma, is how much hyphema is there and how do we go about that hyphema. So maybe the management people will talk about it. So I won't waste my time on that. But there may be very early, very high pressure. It may come down. Then the patient has to go on for angle recession or gonioscopic changes, at least for this thing. The follow-up, I would say, every quarter for first year, every 6 months for second year, and every year till next 15 years of life. So this is how we need to go. And angle recession virtually heal.
Thank
and
you.
That's it.
Yeah, we'll come back to this, ma'am, after
It's
the
okay.
management is
I
over.
think I'm done.
I'll request. Okay.
Yeah.
So I'll request Prasanna to please share, and Karan, you appropriately. Prasanna would be most likely the vice president, and you are the incoming president of YOC. So appropriately, you have to comment on this. Go ahead, Prasanna.
Yeah. Thank you, sir. Thank you for this wonderful opportunity, sir. I'll just start sharing.
Yeah, please.
I'm just sharing my screen, sir, as we speak. Yeah. Yes. Thank you to the whole OTSI team and Devin Tuli, sir, for this wonderful opportunity. Mine is only on management of ocular trauma. So I'll try to avoid overlapping between Vinita ma'am and Murli sir, who has covered etiopathogenesis and the findings that you need to pick up in a traumatic glaucoma. So traumatic glaucoma is a secondary glaucoma as covered by previous speakers, and it has the risk of developing glaucoma being 2.67 and 3.39 for penetrating and blunt trauma respectively. And the classification was also well covered with there is blunt trauma, penetrating trauma, and also, as Murli sir pointed out, we have burn injuries, post-cracker injuries, electrical injury, and radiation injury. So traumatic glaucoma secondary to blunt trauma. So let's see how we manage that part of it, which can manifest as trabecular meshwork disruption, hyphema, traumatic iritis, or choroidal hemorrhage. So let's see how the trabecular meshwork disruption is being managed. So the trabecular meshwork disruption can lead to three arms. One is the ciliary muscle can get disrupted, or the trabecular meshwork fibers itself can go into tearing. And the third is angle itself can go into injury. So depending on what happens, either the aqueous humor, the decreased draining of humor happens where the IOP increases, or there is a ciliary body cleft which happens where IOP decreases as covered previously by the speakers. So the management part coming to it, initial treatment is medical therapy if there is a rise in intraocular pressure. And as Murli sir told, avoid doing gonioscopy at least in the early stages. And also the risk of angle recession should be kept in mind. And long term should always be in terms of escalating the medication if it is not coming under control, with or without surgery if the IOP rise persists. So this is how you go about managing that particular arm. Then the surgery being trabeculectomy or mix, which we will see the end of the other arms as well. Hyphema is another one. Source of bleeding of the hyphema has again two arms. One is the anterior posterior compression of the globe, or the other one is a rise of intraocular pressure acute, which causes the fragile blood vessels to damage. How do you manage hyphema, or rather the trabecular? One second. How do you manage the hyphema? Depends on multifactorial needs, like how does it obstruct, which level is the hyphema, is the sickle cell trait there for the patient? Because if there is a sickle cell trait, then even the deformation and blocked trabecular meshwork to a greater extent. So these are important history that comes with management. And this is also another cognitive chart we need to keep in mind for management. If the hyphema is less than 50, how much of percentage IOP rises? Greater than 50, 100%, but not 8 ball. And if it is 8 ball, how will be the IOP rise? So hyphema is a special concern of management in children, especially if there is a firecracker injury. Hyphema in children happens very early. If there are bystanders having a kid with them, the risk of amblyopia should be kept in mind in those kind of children. Corneal blood staining can happen if not treated. Again, that could also be a cause of amblyopia in very early age group or pediatric age groups. Managing hyphema, controlling the IOP and preventing the rebleed in 3 to 7 days is the key. And aquasuppressants can be used. Avoid carbonic anhydrase inhibitors and alpha agonists in sickle cell disease. Avoid blood thinners. Eye shield can be given. Head end elevation, making sure that there is head end elevation when the patient is sleeping. And bed rest is another one. Clot wash out time is optimal for 4 days. So make sure to keep that in mind. Trabeculectomy and iridectomy if everything fails. And finally, the risk of angle recession also has to be kept in mind. Moving to traumatic iritis, which can happen. So let's see how to go about managing it. I'm skipping the clinical part of it as well covered by the previous speakers. Iritis anti-inflammatory, like any uveitic reaction of topical steroids or non-steroidal anti-inflammatory drugs. Cycloplegics to relieve the ciliary spasm and pain. And of course, topical anti-glaucoma medications. Avoiding prostaglandins is very important. Moving on to choroidal hemorrhage. In choroidal hemorrhage, IOP control again by topical medications. If needed, oral carbonic anhydrase inhibitors with or without hyperosmotic agents. Give cycloplegics to deepen the anterior chamber.
I'll request everyone to please mute except Prasanna. I'll request everyone to please mute. Thank you.
Yes.
Go ahead, Prasanna.
Thank you for chipping in, sir. Steroids to reduce inflammation and stabilize the choroidal vessels, and surgical drainage if the IOP is so high there is a kissing choroid. And another sign is lens cornea apposition. It's so shallow, and doing a B scan to confirm the kissing choroids. Late onset physiology, as discussed by the elite panels as well, we have other different facets like angle recession, phacolytic, lens dislocation, hemocydric, hemolytic glaucoma, and Gosel glaucoma. Let's see one point of only management, which is the fulcrum of this talk. Management of angle recession glaucoma. Medically, you can manage, avoid pilocarpine. That is the very important point. It may worsen angle recession. Cycloplegics can be given if the pupillary block is seen till surgery. Surgically, trab with mitomycin C injectable is preferred. I do have some cases at the end where we have done KDB as well. Glaucoma drainage device has moderate success. Cyclodestructive procedures for poor visual potential. Gosel glaucoma, how do we go about managing Gosel glaucoma? It is usually self-limited. I'm again skipping the etiopathogenesis. Standard IOP lowering therapy is there for the Gosel glaucoma. pars plana vitrectomy, if there is dense vitreous hemorrhage with uncontrolled IOP, seek the help of a retinal surgeon. Hemolytic glaucoma, which is a rare form of glaucoma, and hemocydric glaucoma again, which is another rare form of glaucoma where there is a foreign body causing a toxic effect of the trabecular meshwork. Removal of foreign body is the key in these conditions, and then managing it for the trauma based on the clinical signs. Lens dislocation or subluxation, the lens could be the culprit, which can cause a pupillary block, acute angle closure glaucoma because of anterior dislocation, or a posterior dislocation into the vitreous, which will need the help of a VR surgeon if it is into the vitreous cavity. And there can be open angle glaucoma as well because of intermittent closure of the angle by dislocated lens, uveitic secondary to dislocated lens, or the obstruction of the trabecular meshwork by vitreous. These are things which we need to keep in mind, very rare scenarios which we may encounter. Phacolytic glaucoma, in a traumatic mature cataract, the protein leakage can happen, and the trabecular meshwork overwhelmed with inflammatory cells and proteinaceous debris can cause the angle to occlude or block, causing a phacolytic glaucoma. And management is keeping management for the dislocation part. If there is a pupillary block, contemplate laser or surgical iridotomy and iridotomy respectively, and lensectomy being the major role for cataractus induced causes like phacolytic glaucoma. Other things like burns, as Dr. Murli sir was also telling, that the burns that has its own different kind of management, where there may be shrinkage of the tissue and decreased of the intraocular volume. Often we may resort to cyclophotocoagulation, where that may be the only viable surgery of management. Traumatic due to penetrating injury, as avoid gonioscopy immediately, evaluate the patient and see what sort of spectrum it is entering, and look out for other mechanisms like injury to the other structures, posterior synechiae, which can cause issues, injury to the lens and whatnot, which are other clinical signs, along with a solid history, elaborating the history, severity of the intraocular foreign body, possibility like a pellet or a shrapnel or a bullet, timeline for increased IOP, like it can delay with angle recession, but acute with IFEMA. So the timelines keeping in mind, setting of injury depending on the workplace or school for kids, past ocular history, and then moving on to examination, which was well covered by the previous speakers, which I am skipping. These are some of my own cases of traumatic documentation, traumatic cataracts, splinter injury, lens dislocation, vitreous coming into the AC, and increased pigmentation and widening of ciliary body band and angle recession. Again, this is another case of my own, which again, beyond the scope of this talk, where I'm only going to talk about management. Where comes the B scan? In management, always keep in mind a B scan, a gentle B scan can be tried soon after things settle down. Ocular imaging like UBM as well after you rule out penetrating or perforating injury. CT is one investigation, and the management as such for these spectrum is prevention, viscoelastic to maintain the AC, to prevent anterior synechiae, and topical steroids to reduce inflammation and prevent synechiae during the repair. Acute management is always medical therapy and lensectomy, as we discussed, if lens is the cause. Surgical management, prompt watertight globe closure is very important to prevent infection risk, and careful search of the intraocular foreign body, because that is the paramount importance to prevent infection as well as the hemosiderosis. And long-term follow-up is always the key. I end with one or two cases where I'm going to show videos. One of a firecracker injury of an 8-year-old male, how we managed him. Right eye, you can see 46 IOP with circumcorneal congestion, and we diagnosed with right eye penetrating trauma with secondary glaucoma and traumatic intumescent cataract. Only cataract removal was done with mannitol along with an antibiotic and an IOP reduction medication with homatropin. And the IOP persistent even after IOL implantation, and we had to do a secondary surgery. Trabeculectomy with trabeculotomy was done for this pediatric age group case. It still holds good. This was one of the time during Diwali in 2022, where he landed up with this. We did a standalone cataract surgery alone after the thing stabilized, but that alone was not sufficient. The surgery was done in a phased manner, cataract surgery followed by trabeculotomy with trabeculectomy, where the Schlemm's canal was identified from the outside. And then you can see once the tissue started to ooze with the Schlemm's canal, the outer wall of the Schlemm's canal was deroofed, and then the identification of the canal was done by meticulous dissection, and the Harm's trabeculotome was passed on either side, and then the surgery was completed along with the trabeculectomy as well. Trabeculotomy with a trabeculectomy, as you can see in this video, which is one of the things that I did for this case. Just forwarding it. Once the trabeculectomy punch was done.
Prasanna, you have to tell us a bit about any role of MIGA, so don't forget that
Yes,
part.
yes, I have,
If
sir.
there is any, please tell us
next
very briefly.
video. Yeah. Next one
Yeah,
is
okay,
MIGS.
go
Yeah.
ahead.
So this is how I ended up closing this particular case with 3 sutures, one on the apex and one on both sides. And since this was a pediatric case, a fornix-based flap was not taken, but rather a limbal-based flap for the conjunctiva, as you can see here. That is one of the methods I did. You can see the limbal flap is a limbal-based flap. And the patient did well, and follow-up of 3 years is done, and the IOP is well under control. Coming to the recent advances or how MIGS, the personal experience that I have, case scenario 2, introducing MIGS to traumatic glaucoma. A 28-year-old male cricket ball injury came to us with trauma. And again, as you can see, the patient's left eye, where he had edema, loss of pupillary rough, traumatic mydriasis, traumatic cataract, and there was a choroidal rupture as well, but luckily it was not involving the macula. IOP was 35. And the patient was diagnosed with left eye blunt trauma with secondary glaucoma with traumatic cataract. The patient was on steroids, homatropin, dorzolamide, and timolol was given. And 1 week review, you can see the IOP is slightly coming down, but the eye is healing a bit at 1 week. The choroidal scar is also settling down with the inflammation coming down, and the IOP is still not down. Again, 1 month post-op, IOP is 22. And the traumatic mydriasis, traumatic cataract, you can see in the figure here. 1 month, we are just giving the eye to settle down. And if you had seen the investigation, we didn't do a gonioscopy at 1 week. We did the gonioscopy once the thing settled down at 1 month. We picked up angle recession with trabecular meshwork pigmentation 4, and triple FDC combination medication was started. And now the diagnosis, again, we redefined it as left eye traumatic angle recession with traumatic cataract. And another 2 months, we just thought of conservatively going, and now surgically management was contemplated, and we advised left eye cataract surgery with KDB goniectomy. And let's see how did we go about it. So in view of visual acuity, which was coming down, the vision was coming down from 6.6 to 6.9, 6.12 because of the cataract, and the patient also being a young patient demanded a cataract surgery. Additionally, considering the progression in glaucoma, MIGS was taken into consideration, and KDB was the one we contemplated. This is the OCT of the patient. This is the lens star of the patient, biometry. The patient, why the lens star? The patient had a cylindrical power, a corneal cylindrical power, which actually took, and we thought of going ahead with a toric IOL. A young patient, very active, and you can see the toric marking here. The cataract surgery has been completed, and now going to the mixed surgery after the cataract. So in these kind of patients where they need a quick visual rehabilitation, being a young patient, and you can see that this ciliary body band is nicely broad, and you can see also a trabecular meshwork which is pigmented. And also there is a recession of the fibers, the root of iris, showing a good ciliary body band in the inferior part. So went ahead, did KDB. You can see a neat KDB because the problem in angle recession is predominantly the direct injury to the trabecular meshwork itself, which could be the culprit. And an inside-out approach of KDB, a Kauk dual blade goniectomy was done. And a neat inner wall of the Schlemm's canal was seen. Good dissection is the key. I have personally done KDB procedures and bang procedures for traumatic cases. I have no experience on implant devices like iStent or iDress. I have good experience in the KDB and suture cat, where we have done 3-4 cases like this, where the patients are doing well. And also you can see, since the trabecular meshwork is heavily pigmented, I was able to do a trabeculorhexis kind of a procedure where the trabecular meshwork is so pigmented that you can actually strip the trabecular meshwork. And what I've done here is I just stripped it out, took it out, and kept it on the top of the cornea. If you can see here, this is the trabecular meshwork, the heavily pigmented trabecular meshwork, which is nicely seen. I'm just trying to keep it on the conjunctiva as well as on the sponge. So this is the trabecular meshwork in an angle recession case where it will be heavily pigmented. You can actually catch it with an MST forceps and also strip it, something like a trabecular excess that you can see I'm doing here, catching hold of it and just stripping it like a trabecular excess. You can see this procedure, leaving less remnant as possible. 1 week post-op, IOP was still 22 because of the inflammation post-surgery. And slowly the IOP and the vision started settling down 6, 6, 18, 1 year post-op. And now the patient is on a 3-year post-op with good amount of stabilization of vision. He was on 4 medications before surgery. And now he's on nil medicines because of the procedure that we did. So highlights of these cases, thorough evaluation is always the key. Angle recession happens as a sequelae. Combined approach in managing the cataract and the glaucoma will always play a role. KDB was chosen or mixed as a role when there is astigmatism risk that you are seeing in young patients, risk of corneal from corneal manipulation that you would want to avoid, or invasive surgeries like trabeculectomy, and it controls the IOP very well. There are many other facets, but excisional goniectomy and GAT, suture GAT seems to be working well. And literature, there are some cases being published along with what I showed. Most of them are pediatric oriented. And there are still reports coming up as we speak. And adult traumatic glaucoma as well, we have started going on to KDB and suture GAT. Advantages are preserved conjunctiva, blebless, minimizes the post-operative complications like overfiltration, corneal edema, bleb leaks, hypotonic maculopathy, and whatnot. Even blebitis in the future. And these procedures, if they fail, we can always go back to trabeculectomy. So this is the extensive discussion that I wanted to have on mix. And
Yeah, thank you. Thank you so much, Prasanna.
Thank you, sir.
Great.
Thank you for the opportunity, sir. And,
no problem. No, but stay back. We'll have a panel discussion. Okay,
yes,
Karan,
sir,
are you
yes.
there? Karan? Is Dr. Pradeep Vyas there? Because he's in US, so I don't know if he's joined from some other name. Sir, if you're there, please tell us. All right, Karan is not there. So we can have the last case, and then we can open up for all the panelists. Last talk rather. So Jayanta sir, please invite Dr. Alok Sati, who's a faculty at RB RNR Delhi, and he's presenting in lieu of Dr. Sanjay Mishra. Sir, Jayanta sir. All right, okay, go ahead,
Okay.
Dr. Alok Sati. I think we can see your slide.
Yeah, we can see
ahead,
your
go ahead.
slide. Very
So
good.
am I audible,
Welcome,
sir? Am
Dr.
I audible?
Alok. Yeah, welcome, Dr. Alok. And you will be sharing on the complex cases of traumatic glaucoma. Thank you.
So my request is, Dr. Alok, if you present one, then we can have a panel discussion, and then you go to the second.
Fine.
Go ahead, sir.
So actually, I'm speaking on behalf of Brigadier Mishra, who is currently occupied. So this has already been covered by my previous speakers. This is also been covered.
I'll request you only to go to the cases in the interest of time.
Yeah. So
thank you for understanding.
I'll be sailing you through the difficult traumatic glaucoma cases. This is the scenario 1, which is a 26 years old male. He has come with gradual painless decrease in vision in the right eye for past 3 months and following a cricket ball injury. So the visual acuity was 6/24 in the right eye. Slit lamp examination, no significant finding. But if you look at the IOP was 32, the angle recession was more than 180 and cup disc ratio was 0.7. So obviously this has already been covered why it happened. So how did we manage? The patient was already on 5 anti-glaucoma medications. Still the IOP was 21. The target IOP, what we expected was 14 and it was not achieved. So MIGS was planned. As KDB reduces, we know it 20 to 30% of IOP. So this is the video of that, the KDB procedure that was done at our institute. And you can have a look. This is somehow covered by Dr. Prasanna, but
no, go ahead. I think it's good to have some reinforcement. Please go ahead.
Yeah. Though it is difficult to take the videos at time for this type of surgeries.
I'm going to request after this case, Dr. Mayuri, to please give very brief comments, if she would do
Now,
differently.
this is what we have pulled the trabecular meshwork and has taken it out, shown with you all. And the patient responded with the above treatment quite well, with achievement of target IOP, what we're expecting in 2 weeks' time.
Yeah. Just hold on.
Yeah,
Just pause.
discussion.
Maybe, ma'am?
Yeah. You are right. The patient, how old is the patient's injury? Only 1.5 months? When
Yes,
was the injury? 1.5 months, right?
No, I've already told you, 3 months.
3 months. So by this time, usually the inflammation has subsided. Usually. So it is the scarred trabecular meshwork, that is what we believe. But you said angle recession was more than 180 degrees. Right? So for me, I think I will, rather than doing KDB, I will do trabeculectomy, because these angles are already fibrosed. There is a recession and the intercanalicular spaces could have a fibrosis. So maybe KDB will not work for a long time. That is what I believe. Trabeculectomy or the tube.
Okay, Parihar sir, are you there? Any different approach? Dr. Madhu, ma'am?
I think I'll go with Sati for a simple reason that KDB, you're not losing any conjunctiva. And in angle recession, angle is scarred. So if it can be actually, if the KDB can get off the scar tissue, that is the pathology. We can buy certain number of years. If we look at the patient, the age is very little. So even if the KDB fails in 2, 3, 4, 5 years, we still have conjunctiva for 2 more traps, because these glaucomas are very intractable. So if whatever we can do without actually harming the patient, without losing the conjunctiva, I think that could be the truly an ideal procedure. But yes, technically it should be possible. It's often not possible because in angle recession, the blood goes in the canal of Schlem's and that causes fibrosis. So getting that is really difficult. Therefore, maybe GAT and all may not be the great things, but KDB probably enters better. It's got sharper edges, so it may be able to cut off. But
So I think,
in
ma'am,
180
that is the beauty about glaucoma management, that two stalwarts, Dr. Mayuri and Dr. Madhu, have a different perspective. Ma'am, in the interest of time, we'll come back to you. Alok, please present
Sati
the
is my
second case.
student. I'll stand by him anyway.
Second case,
I agree
Alok.
with ma'am. I agree with ma'am. That's the thought process. Now the second scenario.
You have to, Fauji, na?
No, she's my teacher. I have learned glaucoma.
Okay, go ahead.
Yeah, second scenario is 28 years old. Again, a case of angle recession glaucoma right eye. Here the Cupdis ratio was 0.8, again on 5 anti-glaucoma medication. Still the IOP was 24, but the target IOP 12 was not achieved. And there were extensive pass all quadrants. So here what we planned is trabeculectomy, as it reduces 30 to 50% of IOP. And this is the procedure that what we did at our institute. So after the localized peritomy, we this is a very short video, so it's better to see it. This is a modified trap. What we are doing, we are placing the mitomycin C.
Vaseem sir, we'll request your comments on this once he's finished with case 2.
My comment. I think Dr. Murli is here.
No, I think he's just left, sir, and you and Dr. Meeta can comment on this. You are
Dr.
excellent
Prafulla?
in everything you do, sir.
Yeah, no, Dr. Prafulla is there.
Sir, we'll come back to the third. We'll ask him for the third, sir. You please comment on this, and Dr. Vinita can comment. So what is the modification here, Alok?
It's a modification. It's what we call augmented trab is a modified trab is the other name of it. It's just use of mitomycin C, nothing more than that.
All right.
But I think that is what is being used. Is there any different concentration or a different technique of using mitomycin?
No, same.
Okay, okay.
So just that he has special hands, it always results are good in Alok's hand.
Wow.
So you can comment alongside if you want to.
I think the case is well managed, and trabeculectomy is the answer for such type of patients which are there on 5 AGM and scarring. So a good decision because the patient is young. Naturally, the mitomycin C has to be used, and maybe you can use the releasable sutures.
What was the? Have you used that, Alok, releasables?
We use the normal sutures.
Have you used?
Like, as you see.
Okay.
And the patient has recovered quite well. But I feel that the post-op, what we call massage, or there's just a pressing onto one end, works quite well because I found that works quite well. So.
Great. So you have anything to show in this case? Otherwise, you can go to the third.
Can I add one thing, Devan? Can I add one?
I have a question.
Yeah, please.
See,
The
these are
question
young,
is that
these are young patients, so use of mitomycin should be very judicial. These young patients may go into hypotony, so be careful with the mitomycin concentration, and time duration should also not exceed.
I think mitomycin is indicated for the young patients
It
only.
is indicated, but not too much because hypotony is an issue with the young.
Yeah, there's a specific duration, like if you say 0.2, 2 minutes, like 0.02, 2 minutes, 2 minutes wash, that's the protocol what we follow. And with that, I have done it many cases, ma'am, TRAB in different scenario, like we have different combat patients also who come from Northern Command or Eastern Command. So we haven't find any melt or any such thing, hypotony in any one of the patients, ma'am, to be very honest.
You don't have myopes, you are lucky. If you had myopes, then you would have had
You
more of
will
a
end up with
problem
a
because Amir has fit people. I have only one question. In angle recession, there's widening of ciliary body band. So how did you have so many pass? That was one question was bothering me. That are we dealing with angle recession or are we dealing with something else?
No, I told that in the area of this thing, what you call angle recession, there is definitely no pass, but in the other area, there were extensive
Fair enough.
So we can go to the third case, and I'll request Jayanta sir to comment on the third case.
Yeah, the third case, a 21 years old male, again, an angle recession glaucoma, 0.8 cupping on 5 anti-glaucoma medication. The trabeculectomy was performed in this, but subsequently failed. Bleb revision was done twice, not effective, so we planned for AGV, and this is what we did, the AGV.
That you have shown us MIGS, TRAB, and AGB. And I think we'll request you to finish with this. After we finish, we'll have comments because it's already 9:15, so we'll hang up after this. If that's okay with you, Alok?
Yeah, no issues, no issue.
Yeah. So, Jayanta sir, you have to comment on this and any of the panelists.
Probably we can just wait for the valve surgery initially. I feel initially we can thought for some little bit of more other mode or repeat. We can go for a repeat a repeat trap or in other site. Maybe one of the option. I am not 100% sure, but in a young, generally, that valve surgery is directly after a one failure, two failure. So we can think one is very nicely. Am I audible? Hello?
Yes,
Yes,
yes.
yes.
Yes,
Yes,
yes.
yes. So I just request Prafulla Sharma sir is there. So I
He's
want
there.
to
That
comment.
sir is there. Prafulla
Yes.
sir,
Yeah.
any different approach
Yes,
other
yes.
than
I have a difference in opinion. What I can see from these traps actually, the conjunctival incision was quite extensive. In young patients, usually we always keep conjunctiva, at least second surgery, we always keep the conjunctiva intact. We do it on either at 12 o'clock with minimum conjunctival dissection so that we can do a second trap. And if necessary,
Alok, you can keep playing the video in the interim.
yeah,
Sir?
so
Go ahead, sir. Go ahead.
we should always try to keep some conjunctiva so that we can do a repeat trap, because it is not that the valve surgery is the final surgery. If we do valve as the second procedure, and if there is no space for doing a repeat trap, then I think we'll be in a very difficult position. So
Yes, sir.
one thing we should always remember that while doing a first trap, especially not only in young patients, in all patients, we try to preserve the conjunctiva as much as possible. We do it either on one side, so the other side you can utilize, or even we can do up to 3 taps. So we should proceed accordingly, thinking about the future. That's what I want to comment actually.
Yes, sir. Yes, sir. Excellent.
Yeah. Anything from Mayuri ma'am and Madhu ma'am very quickly on this, and then we close up.
This has gone very
All right.
well.
I'll request Jayanta sir. Okay. Yeah, go ahead, ma'am.
Yeah.
Go ahead, ma'am. Go ahead.
This,
Yeah.
this
Okay.
case has been done, and rest Prafulla has already told. One spectrum is left is CPC. So in army, we do have cases which are cases of blast injuries. So bombs are blasting, then you are left with no conjunctiva at all. In that case, an angle is very badly deformed because of the injury in the anterior and posterior segment. So these patients make an ideal case for primary CPC when the conjunctiva is totally destroyed by the chemicals that are there in that bomb, in those bombs. And vitreous surgery is almost always required. So lensectomy, vitrectomy has all been done. Cornea may be compromised and IOP is very high. So in these cases, primary CPC could be the ultimate spectrum, and that covers the entire spectrum of glaucoma surgeries.
Thank you.
Yeah, thank you, madam. Thank you, madam.
Propose the vote of thanks.
Yeah.
Dr. Dev, please.
Yes, sir. So yeah. Am I audible? Yeah.
Yes.
Okay, fine. So I just thanks especially the speakers. Very excellent talk, each and everyone their own. All the panelists, all they are giving the inputs because it's a very important topic. And that overall, it is all everything was designed and very important talks, important things. It was highlighted by my most brother like Dr. Deben Tuli. He is organized in such a way, and he is organizing, and that we are our executive committee is invite him to organize these things, and I thanks to the whole executive committee for this decision. And at the end, of course, that without the participant is not possible anything. So all the participant and the technical team, with the help of the technical team, is nothing is possible in a science or in basic whatever, in a physical or in a webinar. Very excellent talk, though that the participants are less, but in near future we can try for more participants. Very excellent talk. I congratulate each and every speaker, all the panelists for their very important feedbacks in each and every cases. And
thank you,
just
sir. Thank you, sir. We must thank Basim sir also for this initiative. And I'll also add on behalf of OTSI that the conference is going to be in Amritsar. So I think that's going to be great, and they'll be announcing it very soon.
yes.
It was really good and very nice discussion, and a special thanks to Dr. Madhu Baduria, Madam Khamar, and all the speakers. Thank you all, and Dr. Prafulla sir. And I'm really enthused. In such a short time, you have given wonderful talk, and it was a wonderful discussion at the end of the day. And we look forward to participate in other activities together. Thank you, Dr. Devin, for organizing such a beautiful webinar.
My pleasure, sir, and thank you for the
Thank you,
opportunity.
Dr. Deven.
Excellent.
We
You
are
have taken the
having
call
a live
immediately.
YouTube streaming also, and many PGs and the postgraduates are attending this and joining it. Thank you.
Thank you so
Dr.
much,
Mayur,
everyone.
you want to say?
Good night, everyone.
Good night.
Good night. Good night.
Bye.
Good
Good
night.
night.
Thank you.
Thank you.
Bye. Good
Bye.
night.
Bye.
Bye, Dr.
Night.
Vinita.
Bye.
Let me